Okay, welcome to our members joining the RSSA webinar tonight. My name is Ursula Lees and I'll be coordinating tonight's webinar. The focus for discussion tonight is whole body MRI for oncological disease, why, when, and how. We are privileged tonight to be joined by Prof. Anwar Padani, who will be giving us insight into this topic. Dr. Anwar Padani is an internationally recognized leader in oncological imaging at Mount Vernon Cancer Centre in the London, UK. He holds a professorship in cancer imaging at the Institute of Cancer Research in London and serves as a trustee of the International Cancer Imaging Society and co-chair of the International Prostate MY-RADS Committee. A gifted educator, Dr. Padani has delivered over 450 lectures at conferences worldwide, including several plenary addresses. His passion for teaching has earned prestigious awards like the ISMRM's Outstanding Teacher and multiple honored educator awards from the RSNA. He actively shares his expertise via Twitter and his YouTube channel, featuring free access to most of his lectures. With over 500 citable publications to his credit, including 33 textbooks, Dr. Padani has an exceptional high H index of 76. His articles have amassed over 73,000 reads and close to 30,000 citations so far. He has contributed extensively to the literature through chapters, case reports, commentaries, editorials, educational reviews, and over 200 scientific papers in PubMed journals. Before I hand over to Dr. Padani, I'd like to remind the audience tonight online to post any questions in the chat and Q&A function. These will be addressed after the meeting. Without further delay, I hand over to you, Dr. Padani.
Thank you, Kathy. Good evening, everybody. Thanks for coming along. For the next 45 minutes, we'll talk about why we should be using whole body MRI for cancer and how to do it. These are my disclosures. So the perspective I want to take is from the point of view of the limitations of conventional imaging, focusing mostly on bone disease today. We'll go through some protocols and some common indications, both for detection and for response assessment of disease. I'll be focusing on three whole body MRI guidelines, the MY-RADS guidelines for myeloma, the MET-RADS guidelines for metastases, but I'll also be touching on the OncoRADS guidelines, how these scans should be done and how they should be applied. And then I'm going to talk to you about biases that can be introduced by the introduction of next generation imaging technologies and how we should be very cognizant of these biases and what might be the consequence of these biases. So we know when we talk about bone disease is incredibly common. The first known case of metastatic prostate cancer in the world was 2,700 years ago. And you can see the picture of the Syrian king who had metastatic prostate cancer. But we know it occurs in myeloma, in breast, prostate, lung, and kidney cancers, to name but a few. The problem at the moment is that we assess metastatic bone disease using radiographic techniques, particularly plain X-rays, bone scans, and CT scans. And we have to recognize that these are indirect indicators of the presence of bone marrow disease. And the only time you actually see the bone marrow disease, well, the majority of times you see the bone marrow disease is when there's destruction. In other words, end organ damage. So we can't really predict or depict the presence of malignant disease. So when we say non-metastatic or oligometastatic or polymetastatic, we're probably only about right about the polymetastatic state. So what happens is you end up with false results, false positives and false negatives, which can misguide the therapeutic approach. And I just wanted to show you an example of multiple myeloma. Now, we're still doing, well, in the UK, we've stopped doing this now, but many places are still doing skeletal surveys for looking at myeloma, and there used to be bone density in the myeloma guidelines. Unfortunately, these have now disappeared from the international guidelines. And I just wanted to show you this patient and a typical series of X-rays But just to point out that, if you had disease like this, like this, like this, then, clearly this patient's got myeloma. But do we really get a good feel for the extent of disease? In other words, the extent of disease really determines the prognosis, not the presence of disease. It's the extent of disease. It's only when you do something like whole body MRI that you notice multiple other things, such as this salt and pepper appearance throughout the lumbar spine and this extra osseous disease, paramedullary. That's extra osseous disease in the left hemipelvis. So you can see how we are underestimating the volume of disease at first presentation in this particular instance. And it is for this reason that the international guidelines have actually got rid of skeletal surveys. And, the first statement is skeletal surveys should not be used to assess bone disease in myeloma. And in fact, the recommendation is to use low-dose CT or MRI with whole body MRI or PET scans. Now, you'll notice that for CT scans, it's one or more lesion, more than 5 millimeters in size for CT scans, consistent with the presence of myeloma. So you have to be very sure it is due to that. So osteoporosis becomes a real issue here. And if there's less than 10% of clonal cells, then there has to be more than one lesion. The other thing you'll notice is that for PET scans, it's not the FDG component that's important, it's the CT component that's important for the definition of multiple myeloma. And of course, for MRI, you have to have two, not one, but two, or more focal lesions, and they have to be more than 5 millimeters in size, whereas you see here, it says 5 millimeters in size. Now, the other problem is that we are unable to identify people who are responding in a timely fashion. And so if you look, and this can impede patients' progress to alternative therapies, and this results in increased costs, etc. And I just wanted to illustrate to you this patient. So this is a man at the end of his journey. He's got castration-resistant prostate cancer, and he has old disease and new disease in the CT scans. And of course, we're trying to monitor therapy. We know that PSA is unreliable, and often we're blinded, particularly in clinical trials, as to the PSA. And we have to report this objectively. And, objectively, this was reported as stable. And I think all of you would agree. But you'll notice what happens on the right-hand side. He gets this thing called unequivocal clinical progression. So this patient's fading away. And there's about 30% of patients at the end of their life, they seem to be getting worse clinically, but their radiographs are not changing. Patients who undergo this change with a stable radiographic appearances do very badly. And in fact, I was approached to do a repeat whole body MRI. And you can see on this diffusion sequence, the patient is clearly progressing. And we were then unblinded to the PSA, and the PSA had gone up. So you can see how there was a delay in this man's treatment because we were just using radiographic or CT appearances when this bone destruction or this progression was not being well depicted. So the guidelines that I want to talk to you about today are the three guidelines: the MET-RADS guidelines for metastases, the MY-RADS guidelines for myeloma, and the OncoRADS guidelines for screening. And you can see on the right-hand side, these are some of the publications. So there are a number of sequences that we can do, and I've just sort of highlighted them over here. We haven't got time to go through the whole thing, but just to let you know that there are different regions, there are different sequences, and the question is, how do we fit all of this together to make what is a comprehensive assessment? So there are core protocols, and then there are extended or comprehensive protocols. So the core protocol is what you might imagine: spinal examinations, whole body Dixon techniques, and diffusion imaging. And you can see them over here. And you'll notice here that the Dixon technique is a 2-point T1 Dixon. and you'll see axial or coronal. This is the important word, or, and the diffusion is 2B value. So this protocol for the whole body should take about a half an hour. And here's an example for multiple myeloma. So you can see the sagittal T1 and stirs. You can see the DWIs rendered as MIP images. Here's the most important sequence from Dixon, and this is the fat fraction reconstruction. We'll come back to that in a second. Here's the high B value image, and there's the mandatory reconstruction of the ADC. So this is a core protocol for the whole body, meaning from the top of the head to the mid thighs, and this should take you less than 30 minutes in 2023. Now, the Dixon technique, you'll remember, in phase, post phase, fat, water images, and these are used to reconstruct the T1 fat fraction. And this is a mandatory reconstruction. And of course, this is the lower and the higher B value, and there's the mandatory ADC reconstruction. You can see this salt and pepper appearance here, for example, in the pelvic bone marrow. Now, the problem here is you'll see there are 5 to 6 stations. If you're going to cover this, this can take anywhere up to 17 minutes on a conventional scanner. Luckily, 2023, we've really made great strides and reduced the amount of time. So you can see down here at the bottom, this is the conventional sequence, 2.5 minutes, 2 minutes 45 seconds for 5 stations, and that time adds up. Whereas the new AI accelerated DWI sequences 1 minute 17 seconds. So the entire whole body DWI now takes 7 minutes. And I just wanted to give you an example of somebody with myeloma, and you can see the conventional, there should be an AL there, just noticed that. 14 minutes, the new sequence, deep resolve boost, 7 minutes 25 seconds. So you see how this acceleration is really helping us push this technique even further. And so the core protocol using these new sequences are shown here with the B900, the ADC map, and the fat fraction on the right-hand side. And these deep resolve sequences seem to be helping larger people more. So you can see this lady here has breast cancer. The right breast has been irradiated. There is a metastatic deposit there, quite difficult to see. But with a deep resolve technique, you'll see how that metastasis just pops out. This deposit here in the lumbar spine is actually just as well seen as you might imagine. So here are the raw data. You can see how the right breast has the signal suppressed, and this metastasis in the lung is brighter. And this is what deep resolve does, and it improves the signal from the left hepatic lobe also. So it really does give you quite a lot of advantages, not only accelerating the sequences. Now, the extended protocol or the comprehensive protocol is a little bit more intensive. We tend to do the same sagittal T1s and stirs of the spine, axial and coronal. 3 or 2B values. I must admit, I tend to stick to 2B values because the signal is so much better than it used to be. And we would also always do a T2 sequence just from an anatomical perspective. And you can take the option of doing other sequences. So here is a comprehensive protocol. I always do the brain, looking for metastases. I do a breath held vibe sequence of the lungs. Again, that's only 16 seconds. And here are the T2 images. So here is an adrenal mass in this patient with prostate cancer. This looks like an adrenal adenoma. And there's the fat you can see there in the middle of this lesion. This is the B900. There's the ADC. You can see quite a fast way of doing this. And all of these sequences, so the Sterhaze, the coronal vibe sequence, this is in 3 millimeter cuts, the whole body in 1 minute and 50 seconds. So really, really, really very, very quick to do this. And of course, the MIP reconstructions that you can also rotate. So here are the mandatory reconstructions and the full details of the slicing that you need to do, just so that you can come back and visit this video later so that you can dig into these sequences in more detail. Now, not only are we trying to standardize the imaging, but we also want to provide objective criteria to assess response of bone disease. Remember, that was one of the limitations of conventional imaging, and we have this RAC system, RAC Response Assessment Category, RAC system, and it's 1 to 5, where 1 is highly likely to be responding, 5 is progression is highly likely. So you can think of it, in these terms, where RAC 5 is where you're saying this is unequivocal progression, you should change treatment, whereas RAC 1 and RAC 2, patients are stable or great, just carry on the treatment. So this is how you'd want to think about the RAC system. Now, of course, we all use morphological criteria, and so we should. So what we've done is we've converted morphological criteria into words so that we can give you some criteria. So, for example, RAC 5, progression highly likely, is an unequivocal increase in the number and size of lesions. I think all of us would agree that is progression. Evolution of a focal lesion to a diffuse neoplastic pattern, unequivocal new focal disease, new critical fractures. So this is all stuff that we would recognize as being progression. And here's an example of somebody progressing. I mean, I'm not trying to teach you how to suck eggs, but there is more disease, and well, there's just more disease here. And there's new disease. Now, the important learning here is what happens to the ADC when you have more disease. And this is the learning point. So you can see I've segmented out the disease here, before and after treatment. And you can see it's all red. In other words, it's all bad. But this is the histogram here on the first occasion. Here's the histogram on the second occasion. And you can see this is the ADC value here. And I'm just going to magnify that up for you. So you'll see that the volume of disease has increased from 99 cc's to 271 cc's. But look at the ADC value. It stays exactly the same here. So when you have progression, you just have more disease, but it's the same disease that you had in the first instance. So the ADC should be steady. And that's the important lesson. Regarding response, you have to think in a slightly different way. So response, you see a morphological response, as you can see on the left-hand side, but there are also functional imaging criteria related to ADC and in fact related to fat fraction. So you would expect with cell kill to have an increase in ADC, so that's been incorporated. The emergence of fat in what was neoplastic marrow, so that's been incorporated. And of course, morphological criteria has also been incorporated because lesions become smaller. So morphology, fat fraction, and ADC are incorporated, which is why you have those mandatory reconstructions. So response, highly likely. So a decrease in the soft tissue associated with the bone disease. Yeah. Something disappearing. Yeah. The emergence of fat. Yeah, I think all of us would say that is response. So here is the emergence of normal marrow in areas that were previously infiltrated by focal or diffuse disease. And you can see that in this particular patient. So here's the stairs, here's the T1s. I mean, I think most of us would say there's increased fat. Could be quite difficult, I have to say. Here are the diffusion sequences, and there's some decrease in signal. But when I show you the fat fraction, it's so obvious. Okay, so here is the patient before. High signal on the high B value becomes lower, flu. ADC, dark state goes a bit blacker. But look at the fat fraction. So it was a very low fat fraction. Look at that. The fat has come back. So you can see how this fat fraction can really be very useful for saying something is responding. Hence the reason it's mandatory. But there are, of course, soft tissue criteria that we also incorporate. And here's here's something I think all of us would recognize. So in this particular instance, before, after, before, after, before, after. So you can see how fat's come back. Good. Lesions are smaller. Good. But you'll see there are still areas here where there is residual abnormalities. Here's the liver deposit, and these are smaller liver lesions. They've also got smaller. So this is clearly responding disease, and all of us would call that. Here is somebody with a patient with nodal disease and bone disease, this time in a patient with prostate cancer. And you can see how these retroperitoneal lymph nodes have gone away, and the bone disease is also improved. And you can see fat emerging in this bone deposit here. So everything that we would expect to call response is present. But the important thing is that we have incorporated the ADC criteria, not just the fat fraction criteria. And that's because of this phenomenon. So here's somebody with multiple myeloma before and after just one cycle of ESHAP chemotherapy. And if you looked at the morphological sequences, that's a tough call to say that that is response. Here's the T2. In fact, the signals got brighter. That can be a little bit confusing. But on the DWI, well, that's obviously getting better. We can see a decrease in the signal intensity. So we can already say that the water's moving more, explaining all these white areas that we see in the marrow. But look at the ADC values. So here is the ADC before, a very low ADC, and you can see it here, 653. And this is afterwards. For the same segmentation, you can see that's gone up to 1400. And you, of course, you can color code that and project it back onto the skeleton if you want to see where the response is taking place. But the important observation is this increase in the ADC value accompanied by a decrease in the high B value projection images. And that is the reason why ADC is incorporated into the MET-RADS guidelines. And of course, all these observations then need to go back to your clinicians. So there are standardized reporting templates. So this is the MET-RADS template for prostate cancer. This is the MET-RADS template for breast cancer. And this is a more boring looking template for multiple myeloma. Now, some of you may say, well, where's the validation for all this stuff? And that's what I want to show you next, and to show you the progress we've made in the validation. So you can obviously drill the bones. If you drill the bones and look at the number of cells and then correlate that with signal intensity, ADC, and fat fraction, what you notice is, so this is the signal intensity. So bone metastases positive for tumor foci, higher signal intensity. We all know that, okay? Fat fraction, right? Bone deposits positive for tumor cells, low fat fraction. Okay, and an ADC value that is intermediate. So bone metastases negative for tumor cells, you see, a higher ADC value. And non-metastatic bone comes up as has a very low ADC value. So you can see this is by drilling the bones. More validation, again, with drilling the bones. Now, this is where it becomes really interesting. So if you have a high signal on a high B value, low on an ADC, and a low fat fraction, what you'll notice if you drill that, what is the chance of that being a metastasis? So in other words, what's the sensitivity of that observation? And it's 80%. 80%, that will be positive for tumor cells, and there's a 91% chance that if you were to drill that, harvest the DNA, you would be able to do genetic sequencing on that DNA that you obtain from that. Okay, now why is that important? Well, that's important, and I think I just illustrate the reason why here. So here, for example, is somebody with prostate cancer. He had this lesion here in the left iliac bone, so high signal on the high B value, low on an ADC, drilled it, and has a BRCA mutation. The patient gets treated with a PARP inhibitor, and you can see that the ADC value goes up. And we already said, if the ADC value goes up, the patient is responding. You see, if it's gone up from here to here. Patients responding. But look what happens later. On the contralateral side, you see here, you've got a lesion that's emerged that has a low ADC. Interesting. So if you drill that bone, you'll see that the BRCA mutation has reversed. So you can see how you might be able to use this information to target the right place to be able to find out what's going on so you can use the right treatment. And this is the whole essence of precision medicine. So you find out what's wrong, you find out what the mutation is, and target it with a particular therapy if it happens to be available. And this 20% figure has been shown by a number of authors. For example, this was a recent publication in 2022 from China, and you'll see the cutoff value was also 20% here. So you can see how there is other validation coming in. Now, some of you will say, well, what's the reproducibility and observer variability? And that's a very valid question. So let's just take one of these studies. If you look here, the important thing to do is to look at the within patient coefficient of variance here, WCV. And you can see that the inter and intra-observer variability is about 14–15%. And this is the most important figure, the test-retest variability. So what that means is that you can be confident at a 95% level that's a real change is almost 1.7 times that. So it's going to be about 32%, something like that. Yeah. And that's why the 30% figure appears, in fact, in the guidelines. So we've said 40%. But so if you have a more than 30% increase in the ADC value, that's a real figure in the right direction, i.e. towards response. So that's why that figure is there. And this WCV, in fact, confirms that. Now, so on average, how much do you expect the ADC to increase for viable versus non-viable disease compared to that reproducibility? And that's the important question. And this was shown actually very nicely in this paper. These are non-viable and these are viable prostate cancer metastases as depicted by PSMA PET scans. And the difference between the non-viable and the viable is 63%. So there's a big difference between viable and non-viable, and it turns out the reproducibility of your technique, in this particular instance, ADC, is 30%. The WCV is 15%. Remember, it's 1.7 times that, so it's about 30%. And it's well within the test. It's well within the what you would want to pick up to say that these cancer cells were not viable. And here's the repeatability here, given here as 13% in this particular instance. So this group was actually doing much better. They said they could be confident that a change of more than 140 micrometers squared per second is actually real, or 13%. Okay, now it turns out that ADC is also a prognostic marker. That's interesting. So you'd think, okay, so the lower the ADC, the worse the patient's going to do. But if you look here, you'll notice that the worst prognosis of these patients here, this is progression-free survival, this is overall survival. These people have a high ADC. Look at that, 7.5. And then you'd be scratching your head and thinking, well, that's opposite to what I might expect. You know, more cells, more cancer, ADC should be lower. That's not true. You might want to remember that in tumors within the bone marrow, the greater the infiltration, the higher is the ADC value. And this is shown quite nicely over here. You'll see here, control, hyperplastic bone marrow and myeloma, and you'll see the ADC goes up. This is, of course, on a log scale here. So the ADC actually goes up with increasing infiltration. And then some of you might say, well, why is that? The reason that happens is that as the tumor infiltrates into the bone marrow, so it displaces fat. And remember, fat impedes water much more than small cells. And that's why as tumor populates the bone marrow, it gets rid of these fat cells. As a result, the big giant fat cells, which repel water and decrease the ADC, go away. And therefore, actually, paradoxically, it increases, which is something that many of you may not be aware of, which is very different to soft tissues. Remember, in soft tissues, it's exactly the opposite way around. The more cellularity, the lower is the ADC, but in the bone marrow, it's the opposite way around. So this is one of those exceptions. Either you know it or you don't. Now, here is the fat fraction. You can see similarly, normal, hypoplastic marrow, and fat fraction. And look, it's 13, 14% in multiple myeloma. And remember that figure that I gave you earlier, 20%, right? So that's the cut in here, somewhere in here, between this and this. And that, again, a different piece of data validating the same concept. Now, it turns out that the more cancer cells the more cancer foci you have, the worse your prognosis is going to be. Yes, of course, that's going to be true. But it's validation, nevertheless, of the MET-RADS system, saying you can count the number of deposits. The more deposits you have, the worse you're going to do. And if you have visceral deposit, you're obviously going to be worse. But I showed you some volumes earlier, but the volumes also predict for prognosis. Here's the proportion surviving in patients with prostate. What was this? I can't remember. Was this prostate cancer? No, this is breast cancer. Yeah, this is prostate cancer. So here you can see low volume, high volume. So the higher your volume, the worse you're going to do. Now, what about the repeatability or the variability of the RAC system? I'm encouraging you to use the RAC system, response assessment categories. So how about that? Well, so this is interesting. So if you look at bones and you compare a resident to a consultant radiologist, you'll see all of these are blues. Look at this. It's excellent to substantial inter-observer agreement, both in soft tissues and in the bones. So in other words, your resident could tell you how well a patient is doing, right? So the reproducibility is very good. Remember, this resident is only six months old. Well, not 6 months. I've only been training for 6 months. Okay, so it turns out that these RAC categories are, in fact, quite efficacious in the clinic. And here are a couple of papers in the last couple of years attesting to the power of the RAC for assessing things like minimal residual disease in the setting of myeloma. And you can see MY-RADS RAC criteria could independently stratify patients and predict long-term outcomes and prognosis. So in other words, your response, according to that RAC system, could actually be very helpful for this condition called minimal residual disease. In other words, the tumor that's left at the end of treatment. So you can see this is clinical efficacy. What about efficacy in terms of prostate and breast? Well, even there, it seems to be quite helpful. So this is data from Milan with 30 men with metastatic castration-resistant prostate cancer getting a new line of therapy. And here you'll see they did 12 weekly CT scans, bone scans, and whole body MRIs, and clinic visits, and blood tests. In other words, the clinical routine. The interesting thing was that when progression had occurred, and progression had occurred, you'll see here, progression occurred in 28 patients, 30 men, 28% had progressed by the time they read this out. And you'll see that only in half of the cases, right? In half of the cases, the progression was only on the whole body MRI. In the other half, it was both on CT and bone scans and whole body MRI. So in other words, the whole body MRI always predicted for progression. The CT scans only predicted about half the times. And in fact, when you knew a patient was progressing, these 28 people, when you knew these patients are progressing, only 85% of cases, right, you couldn't detect that progression on a bone scan. So don't do bone scans for looking at progression in the setting of prostate cancer, because you're going to get it wrong. And it's not very efficacious. And here is an example of somebody who's obviously progressing on the whole body MRIs. And you can see this is about 12 weeks. And this is RAC5. This is response assessment category, definitely progressing. And you'll see I'm not sure that you can read out that bone scan and say this is worse. I mean, you might say it's better, but you certainly wouldn't say it's worse. And ditto on the CT scans. So beware of that. And in fact, the same thing applies with breast cancer. So here I took 43 women with bone-only disease, and again, CT scans, bone scans, clinic visits, blood tests, the whole lot. And you can see that patients, the progression had occurred in 33 people with a RAC5 out of these 43. And 2/3 only progressed on the whole body MRI. And the other third had progressed both on the CT and the whole body MRI. In other words, the whole body MRI always predicted progression. There was no patient that progressed on the CT, and we're all scared of lung deposits, yes? But you could see, because you can see lung deposits. And in fact, when you knew patients were progressing, in this particular instance, 50% of patients who you knew was progressing, the bone scan was not detecting it. And here is an example. So here's an example of somebody who has a RAC5, response assessment category 5. Why? Because there are new lesions, there are more lesions. But if you look at the CT scans, if you look at that, I don't know how many of us would say this patient is progressing, you need to change treatment, in other words, RAC5. And would you say that on the bone scan? I think that's a tough call. Some of you may not, but on a prospective read of somebody who's been doing bone scans for 20 years, that was their report, disease extent unchanged with no increase or decrease in the volume of disease. So the whole body MRI, it's obvious. On these radiographic techniques, we need to be much more careful. So really some powerful validation coming through. So when do you use these techniques? Well, multiple myeloma is the obvious place to start. And you'll see the major role is in the detection of myeloma-defining lesions. So not response assessment, but the detection. In breast and prostate cancer, it's detection, characterization, and response assessment. And the OncoRADS system is used for cancer predisposition syndromes, and we'll come to that shortly. So if you look at the guideline, you'll see this is the International Multiple Myeloma Working Group guideline, and this is the UK NICE guidelines. You'll see in the USA, they say do a PET scan first. If inconclusive, do a whole body MRI. Whereas in the UK, we're the other way around. We'll say, well, we know that MRI is better than PET, and so we will do whole body MRI first and then do a low dose CT second. And that's because in the UK, the PET scans are much more limited, and whole body MRI scans, we have about 30 centers, 40 centers in the UK that do this. Whereas in America, the whole body MRI is so expensive. I don't know if you know, but it's in some places they charge $30,000, $40,000 for a whole body MRI scan, which is just crazy stuff. But that's a different discussion. And some of the reasons why you might want to use whole body MRI is to find the place for biopsy. Remember, I showed you those bones that could be drilled. You could diagnose multiple myeloma and therefore the start of treatment. You could detect paramedullary disease, extramedullary disease. We talked about prognostication. We talked about minimal residual disease. We didn't talk about hyposecretory disease, there are multiple other indications. So remember, this technique can be quite efficacious. And you look at the ASCO guidelines, and these are the ASCO Advanced Prostate Cancer Guidelines, and you'll see recommendation number 2, one or more of these modalities should be used, conventional CT and or next generation imaging. And in next generation imaging, see PET CT, PET MRI, or whole body MRI. So even in the ASCO guidelines, the whole body MRI is now emerging as a recommendation, even in the USA. And these are the indications that we do, well, on a daily basis. You know, we are doing 12, 13 whole body MRIs per day nowadays. And these are some of the indications that we are doing. And I've shown you examples of this, but I'm not going to dig into this, but talk about the next guideline, which is the OncoRADS guidelines. And I think it's important to go into this area. So the OncoRADS guidelines is guidelines for basically for cancer screening. And for cancer screening, you're obviously going to cover more of the body depending on the predisposition of your patients. So you can see on the right-hand side, that is for a Li-Fraumeni syndrome patient. So the guidelines are very similar. So you've got the sagittal T1 and STIRS, and the brain images, particularly in Li-Fraumeni syndrome. You'll see this patient had an NF2 and meningioma in their family. So we did a couple of brain MRI scans, and the only thing I found in this lady who had abdominal and right iliac fossa pain was some endometriosis here in the region of the left ovary. But you can see the quality of the images that you get, and you know the sort of coverage that we would cover to look for these family predisposition syndromes. So here is a patient who had NF1. We knew he had an optic nerve glioma, and you can see the optic nerve glioma over here. But what we didn't know was this. So this is a brainstem glioma, and obviously some dural ectasia. And you can see something here in the cervical spine. So this sort of comprehensive protocol in this young man, for example, is something that whole body MRI would enable you to do. This is a patient with known Li-Fraumeni syndrome, TP53 mutations. And, you know, we knew there had been 2 previous brain tumors that had been excised. She had bilateral mastectomies, no adjuvant therapy, and this was to rule out other stuff. And, you know, in the process of ruling out other stuff, look what we find, a completely unsuspected large axillary nodal deposit. So this is the sort of power of the technique, but we know these patients can get sarcomas. So that's why we would go all the way from the top to the feet, because we're also looking for musculoskeletal neoplasms. And in fact, if you look at the whole body MRI guidelines, the Li-Fraumeni guidelines, they recommend doing a whole body MRI. And the way you read these scans is slightly different. So for example, if you were doing general population screening, and I don't recommend you do this, I do it, but I don't recommend you do it, then the way you read is very different according to the OncoRADS categories to a higher risk population. So regarding the higher risk populations, if you have equivocal or highly likely to be malignant, then you should investigate and biopsy. Whereas if you have general population, and I don't recommend you do this, but if you do, then indeterminate scans are most likely to be benign. In fact, it turns out, and there've been tens of thousands of patients who have been looked at with MRI, and we kind of know that the category 3 in the general population, the prevalence is about 2.5%. And of course, the general population prevalence of cancer is about 2 to 3%, as it turns out. So it's background level. So do not overcall indeterminate lesions in a general population, but do overcall in a high risk population, because that is very different. The circumstance is very different because the pretest probability is, of course, very different. Lastly, what I wanted to talk to you about was about biases, and biases are important. Now, we talked about this new technique. It improves detection, i.e. sensitivity. It improves the likelihood something's going to be malignant, i.e. specificity, and it helps us in bone characterization. But this leads to biases, and these are biases that you all need to be aware of. And stage migration is an important bias to be remembered, and of course, lead time and length time bias. So stage migration bias. Whenever you have a technique that detects disease at an earlier time point, you're going to get stage migration bias. So you can see that these techniques all have a higher sensitivity than conventional imaging. Here's conventional imaging here, for example. Now, if you diagnose disease at an earlier time point, so here we have conventional imaging, you would diagnose here. This is how long the patient would live if you treated the patient. If you diagnosed earlier, but used the same treatment and the patient still died at the same time point, then that improvement in survival here is just lead time bias. And you need to be really careful about this because we see it and it's real. So that is a spurious increase in survival. Length time bias. Length time bias is when you overdiagnose indolent cancers. So you do a better technique. Not only do you diagnose metastatic disease, but you also diagnose these small volume deposits that you may never run into trouble with. And then you start to collect all these patients with more indolent forms of metastatic disease. And there are indolent forms of metastatic disease. Smoldering myeloma, I suppose, is the classical example. You don't want to call smoldering myeloma myeloma because all you do is get a length time bias. So you have to be really careful about diagnosing more indolent forms of cancer because that way you can spuriously, again, increase the biases. And these biases can actually, work its way into survival curves. And look what happens here. Look, here's conventional imaging. You have metastatic and non-metastatic, and there are some survival curves with, say, a theoretical curve. So people who are non-metastatic are going to survive more than patients with metastatic disease. Now you put in next generation imaging technologies, and what happens is this false negative patient ends up here. This false positive, which was in the metastatic group, degenerative change, whatever, ends up over here. Well, so that's your improvement in sensitivity and specificity. Okay, but what happens in terms of survival? Well, what happens is this group here has better patients because that false positive moved in there, so they survive longer than before. And these indolent cancers, which you have overdiagnosed, you put them in here, and therefore they live longer. So you see how lead time and length time biases are acting to improve survival for everybody. So suddenly you say, I'm doing a new test, and look, lo and behold, everybody's living longer. Well, are you sure? It's not your test that's causing patients to live longer. It's the biases that you have introduced that causes patients to apparently live longer, because all these patients are still going to die at the same time point. All you have done is, shuffle the chairs on the deck of the Titanic. It's still going to sink. So just be very careful about these biases that one has to be really careful about. Okay, so I'm going to stop there with my final points. So these MET-RADS, MY-RADS guidelines provide the minimum standards for whole body MRI, data acquisition, how you interpret it, and how you report it, both at the baseline and for follow-up, in people focusing on bone marrow malignancies. The guidelines are recognized for multiple myeloma, for familial cancer syndromes. In many places, whole body MRI is now incorporated into the care of prostate and breast cancer in patients, particularly with bone predominant disease. The full clinical validation needs to be proven in breast and cancer and prostate cancer. What that means is, do we know that these techniques will actually help people live longer and better lives? That's where that bias comes in. And I'm not sure we have nailed that point, and that piece of validation still needs to be done. If you are interested in learning about whole body MRI, then you can come for the SACA conference next week in Cape Town. or you can do a course with us online in December. So, you'll see, you'll have all these great teachers who will teach you about whole body MRI on a case-based teaching online. Thank you very much for listening. I hope that you found some of these comments useful. And if you look at my YouTube channel, then a lot of my lectures are there for you to look at and enjoy. Thank you very much indeed.